El audio está muy fuerte, la música. Hi, Michael, how are you?
Jaime, how's Mexico?
Oh, it's a very great day, sunny, 27 degrees Celsius. It's 7 o'clock at night in Mexico City, 8 o'clock at night in New York City, right?
Yes, it is.
Yeah. Well, it's unbelievable, but this is already our fifth program. To all our viewers, we remind you that each week is different. When we are in an English straight audio, we are broadcasting at 20 hours New York time. And next week, when we meet again, it's going to be 9 p.m. Mexico City time, and it's going to be in Spanish. But as always, when we do the program in English, it's translated into Spanish, and we do the program in Spanish, it's translated into English. How have you been this week?
I never had a bad day my whole life.
Oh, that's great to hear.
Yeah. What about you? How's dentistry doing?
Well, it's. I think this COVID has bring us many good things, and has taken us a few things from us as well. And one of those is to practice with fun. It's going to take a few weeks to get used to work with this armor on top and thinking or overthinking what you can touch, what you shouldn't touch. We're just so full of these ways to move our hands and take things from drawers with no. And now we have to be extra careful for everything. But anyway, this is at least we can still practice. And slowly, Mexican dentistry is coming back to work. And we're going to have to live with this for a few weeks, months, maybe a year and a half. Who knows?
Yeah, absolutely. And the same thing in the United States. I mean, most dental offices are completely open right now. And it's a new abnormal. We have to figure out how to make it normal, I think. And with that in mind, I think it's very fortunate for us today to have with us three very, very prominent, talented experts when it comes to dental education. Because not only are we practicing today, we have to figure out how to practice in the future as well. So I'm very excited about the program here today, Jaime.
Yeah, I just want to remind everybody that all of us who appear in this program, we do it pro bono. We don't get any kind of honorarium from anybody. Although the production of this program has sponsors. And I want to thank Dentadec, which is a Mexican company. I want to thank AMIC, the Mexican Association of Dental Dealers and Manufacturers. And I want to also thank Colgate, Palmolive Mexico, for being so kind in supporting this new way of trying to bring dental education into everybody's house, home, practice, anywhere in the world. This is a very nice way to use technology, don't you think?
It's fantastic. I mean, and I think that's probably a lot of things we're going to hear today as well, how we're going to use technology in the future in order to forward our profession. I think with this type of pandemic, there are challenges, but also opportunities. And I hope and I think that we're going to learn a lot from this pandemic, and dentistry is probably going to come out much better than it was before.
Oh, this is always the case. At least it has been. And I want to welcome our three guests into this program. And I'm going to let you introduce them. Just right now, the three of them, and then later on, each one with their CVs, short CVs.
Yeah, so Linda Niesen, thank you very much for joining us. Linda has an extensive background in dental education as well as in academia. I think you were a television star some years ago as well, if I recall correctly. So thank you for joining us again. I'm going to go more into my details about your bio a little bit later. Lily Garcia, I've known her for many, many years. She moved from the Midwest, from Iowa out to UNLV, out to Las Vegas. I presume it was a gamble, but I hope the gamble will play off. I'm sorry, there was a player word. I apologize. And Ellie and I have known each other for many, many years. Both of us graduating actually from the same dental school, some years apart. But I've known Ellie from the time he's been here in the United States, and we have been colleagues and friends for a quarter of a century at least. So Ellie comes also with some very special insights here, both as an educator as well as a researcher. And it's going to be very interesting to hear what he has to say, because Ellie, contrary to Linda and Lily, runs a program for postgraduate education.
Yeah, well, I think it's a great, because we're going to have a director of a postgrad program. We're going to have an on-running school, and we're going to have a school to be, right?
That's right. So Linda is a founding dean, and her dental school's going to open in 2 years, I think, in 2022. Yes. Mm-hmm. Lily took over around a year ago at UNLV. So with that, Jaime, are we ready to get going, or how do you want to do it?
If you want to introduce the CVs of our guests, and then We'll have to go to a little short from our sponsors.
All right. So Linda Neeson, DMD, MPH, MPPD. Linda's currently serving as a founding dean in College of Dental Medicine and vice provost for oral health affairs for Kansas City University, Kansas City, Missouri. Prior to KCU, she served as chief dental officer for Dentsply International and professor at Baylor College. And she's also the immediate past president from the dental school at Nova Southeastern University down in Fort Lauderdale. Linda is a diplomate of the American Board of Dental Public Health and American Board of Special Care and Dentistry, and she has a very, very extensive CV. Just so you know, she has 3 degrees, a DMD degree, an MPH degree, and NPP, Master in Public Policy, all from a school I haven't really heard of before, but I think it's called Harvard or something like that. It's up in Boston area, I think. Yeah. So Linda is highly qualified, obviously. And one more thing I have to add, by the way, Linda is also chair of ADA's council, the American Dental Association's Council on Dental Education and Licensure, which gives her a tremendous insight on not only where we are, but where we're going to go as well, obviously. Lily Garcia is now the Dean and Professor at University of Nevada in Las Vegas, dental medicine. Lily is a prosthodontist, was in private practice for many years, and then somehow got into education. I don't know what made her do that, but has transitioned from private practice, became chair of Department of Restorative Dentistry at University of Colorado Health Science Center, School of Dentistry. And after that, she moved down to University of Texas Health Science Center and was there department chair of prosthodontics in 2001. And after that, she became director of division of advanced education and external affairs. And from there on, went to Iowa. Was the last time I met you, Lily, I think, was when I visited you in Iowa, where she was professor and associate dean for education at the University of Iowa College of Dentistry. That was from 2013 to 2019. And since 2019, she is now the new dean, or the newly appointed dean at the University of Nevada, Las Vegas School of Dental Medicine. Eli Eliav, he is director of the Eastman Institute for Oral Health, and although his title is director, is the same thing as dean, more or less. Eli, you can correct me if I'm wrong, but so he's director of Eastman Institute for Oral Health, vice president for Oral Health at the University of Rochester Medical Center, the vice dean for Oral Health within the School of Medicine and Dentistry. He was previously the chair of the Department of Diagnostic Sciences and director of the Center for Temporomandibular Disorders and Orofacial Pain, and the Carmel Endowed Chair in Anesthesiology at Rutgers School of Dental Medicine. At that time, it was the UMDNJ, University of Medicine and Dentistry of New Jersey. He graduated from Hebrew University at Hadassah in Jerusalem, did a stint also at NIH, and received also both his dental degree and his PhD from the Hebrew University in Israel. And since 2008, he's also served as the editor-in-chief of Quintessence International, and is now also associate editor of Journal of Orofacial Pain and Headache. Eli is an active researcher, specifically orofacial pain, and has published numerous publications, and also has a lot of funding, both internal and external funding from NIH and other sources as well. So I'm absolutely delighted the three of you could join us here today.
Thank you. It's our pleasure. Just to add that you gave me the first position in the United States in 2004. You recruited me to Rutgers.
Well, I hope you don't blame me for that.
I thank you for that.
Okay.
Well, Michael, no, thank you for inviting this tonight's guest. We'll go to a very short video, and then we come back with our first presenter.
La línea Guard también ofrece soluciones para quien presenta problemas en las encías. El ya conocido enjuague bucal Colgate PerioGuard con clorhexidina al 0.12% ayuda a controlar el nivel de bacterias presentes en boca. Debido a su amplio espectro bactericida, reduce hasta un 99% las bacterias bucales, reduce en un 48% el sangrado gingival y hasta en un 54% la placa bacteriana. No contiene alcohol, tiene un sabor agradable a menta, fácil de utilizar y con altísimos estándares de calidad y validación científica que lo distinguen de otras clorhexidinas. Al enjuague Colgate PerioGuard se le unen dos nuevos productos que complementan y ayudan al tratamiento de las personas con problemas de encías. La nueva crema dental especializada Colgate PerioGuard con una fórmula a base de zinc que garantiza una acción antibacteriana prolongada que ayuda a prevenir la inflamación de las encías, la formación de placa y sarro dental. Ayuda a prevenir el sangrado gingival hasta en un 66.7%. Puede ser utilizada de forma diaria y prolongada, ya que su principal ingrediente activo se encuentra de forma natural en el cuerpo humano. Y por último, el nuevo cepillo dental especializado Colgate PerioGuard, de cabeza compacta, mango ergonómico antideslizante y con exclusivas cerdas cónicas Perisoft ultra suaves con puntas de filamentos microfinos, garantizan la eliminación profunda y eficiente de la placa bacteriana sin dañar las encías. Gracias a su cabeza con anatomía diamantada y componente de caucho, evita traumatismos durante el cepillado. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
Well, Mike, we're back, and it's time for you to start with our first presenter.
So, Linda, you're up.
Okay.
Where do you think we are, and where are we going, and what can we expect?
Well, first, buenas tardes, and muchas gracias for the invitation to be here. I'm really honored to speak to everyone about the future of dental education post-COVID-19 and from the perspective of a founding dean. We are in the Kansas City University, which has a medical school, an osteopathic medical school since 1916, is embarking on starting a new dental school in Joplin, Missouri. In about 2 years, we anticipate the accreditation process and the building of the new school will take 2 years. So this evening, if I could have the next slide, please, I'd like to speak about curriculum modifications and the future, focusing on our didactic education, simulation education, the clinical patient care, and interprofessional education. Next slide, please. The didactic education usually is the first 2 years of the dental school. And during this COVID-19 pandemic, we watched dental schools around the country, around the world, transition from, in-person lectures to, synchronous distance learning. Offering the real-time lectures, recording the lectures so the students could watch it later. And they often posted the lectures in a learning management system. In the US, we use Canvas or Blackboard. And a learning management system, think of it as Dropbox or Box, where it's a portal, it's a web portal. The faculty places the syllabus, they place reading assignments, they may place, written assignments as well in this portal for the students. We shifted to remote access assessments. So now students are taking their tests electronically, but rather than in a classroom using the computer, they're taking their tests electronically at home. And at Kansas City University with our osteopathic medical school, we used a test at your own convenience approach, where the exam would be open from 9 a.m. to 9 p.m. If it was a 1-hour test, the student could log on at say 3 o'clock in the afternoon, they'd get a code. Once they entered the code, their computer's locked down and they have an hour to take the test. And they use exam proctoring. In this case, we use Exam Monitor, or Proctorio is another electronic proctoring software that you can use. And it basically uses the student's camera on their device, whether it's an iPad or a computer, to monitor their eye movements and their movements while they're taking the test. What we've seen is we've seen students defend their thesis. We've had seminars using Zoom and LifeSize and virtual meetings for labs where students are doing research. When we think about didactic education in the post-COVID-19 world, clearly these distance learning processes will continue to some extent. And the other thing that we've seen is that remote learning and this web-based ability brings people together from around the world. You know, Michael, you're in New York, Jaime, you're in Mexico City. It's conceivable that in the future, you may see 2 or 3 schools get together, 3 or 4 schools get together and say, hey, let's hire the best physiology professor, the best oral histology professor. Let's put an asynchronous course. Let's record the lectures, make it available to students at these 3 schools, teach it whenever it fits the curriculum, do remote assessments, and it may save costs. It may save the costs for developing courses for various schools. So I think we'll see the asynchronous learning continue, and it may eventually transition to an on-demand or self-learning. Next slide, please. And on-demand learning, what on-demand learning would look like is that students would enroll in a dental school and they could do part of it, didactically in maybe, 10 to 18 to 24 months. We might see students complete the asynchronous learning from any location. And then once they complete the remote assessments, they could then come to campus for simulation or clinical patient care. So the time on campus could conceivably shorten. But the question is, can the Commission on Dental Accreditation, would they consider changing the time frame that's required for dental education? Next slide, please. Next slide, please.
La que sigue, por favor.
So if we think about simulation, thank you. If we think about simulation education, during this pandemic, schools have created various distance learning simulation exercises. And as we move forward, can students perform these simulation exercises off-site? Students have type it on teeth. They have electric handpieces. They watch videos asynchronously. They can watch the video. They can practice, at home or off-site. They can check their preps. There's now software for what we've learned from the digital technology in the CAD/CAM world. So there's software called Prep Check that you could check a preparation. So the students can theoretically check their preparation. When they feel ready to take a simulation competency, they can then come to the school and take the competency. As we think about video conferencing and telehealth, we may use those formats to begin the teaching of patient assessments for taking medical histories and patient interviewing. Next slide, please. So simulation education post-COVID really is forcing schools to look at what activities need to be directly with the patient and which can be off-site. And there's lots of new technologies. There's augmented reality, virtual reality, haptics. Will we see those begin to be used for simulation education in dentistry? So will we see schools use teledentistry for simulated patient interviews and patient encounters? And will telehealth play a greater role? Next slide, please. As we move to clinical patient care, the clinical education really, we're seeing a modification of the clinical environment based on CDC's guidelines for dental settings. We're thinking about patient safety, clinician safety, infection control, and then engineering controls in the building. So we're seeing dental schools, as they begin to reopen, figure out how do they implement physical distancing. How do they keep patients at least 6 feet apart in the reception area? How do they treat patients and make sure the operatories, the patients are within 6 feet in clinical areas. And then the question is, will this continue once the pandemic subsides? Next slide, please. So when we think about clinical education, we think about patient safety. Jaime, you started the program saying, dentistry's, it's different now. It's not the same. We've got to do an assessment of the patient. The patients are certifying. They're taking, a questionnaire, completing a questionnaire. Have they been with anyone who's been diagnosed with COVID-19? What's their temperature? Have they traveled? We're taking their temperature on site when they come to locations. We're identifying whether they're an emergent patient or whether they have a non-emergent need. And do they require a procedure that will be an aerosol generating procedure? From the clinician's perspective, we're doing the same thing. Clinicians are certifying that they're healthy, that they have not been with a patient who's been COVID-19 positive, that their temperature is below, 100.4. And then they're certifying that they're healthy as they come to work. And then we have the infection controls that we've had in the past, but we have a few more now. The use of an N95 mask. We're seeing, the face shields, hair coverings that we haven't seen in the past. And then the cleaning and disinfecting of our surface areas, in addition to the sterilization of our instruments. But we're also looking at engineering controls. Next slide, please. And the engineering controls are really important for a founding dental school. One of the things we've discovered is we're building a building. We've had to go back to the designers and have them relook at the design because of COVID-19. What we need to do is we need to make sure this new building meets the CDC guidelines. So usually with dental schools, you have an open bay. We're now having much higher barriers between each of the operatories. We've changed the reception area to have much more space between the various seating in the reception areas. We have more enclosed areas, the operatories. We've changed the HVAC air filters, and we've added HEPA filtration in the system as well. And the question is, if you're going to treat COVID-19 positive patients with aerosol generating procedures, do you need a negative pressure room? Will you build a negative pressure room in your clinical facility? Next slide, please. So these are the engineering controls we've addressed. As you think about the future, this also may be an opportunity for more interprofessional education. It may, the distance learning, the video conferencing may allow it to be much easier to interact with other professions. Next slide, please. And finally, the Commission on Dental Accreditation, which accredits dental schools in the United States, is really addressing all of these changes. They have to work with the U.S. Department of Education, which provides guidance. And the question is, will the Department of Education give our Commission on Dental Accreditation the flexibility they need to modify their procedures? So how will assessments be done? Can they be done, continue to be done remotely? How will site visits be done? Right now, they're in person. Can they be done remotely? So the future of how we deliver dental education has the ability to change dramatically as a result of this pandemic. But I think we need to keep in mind that we want to make sure that we improve access to healthcare for the patients that we're privileged to serve. So thank you for the opportunity to be here, and I'll be happy to answer any questions.
Wow, thank you. Thank you very much. We're going to go to the question and answers at the end of the three presentations. Okay. What do you think, Mike? I think you're muted.
I think it's very exciting, and I think there are opportunities here, and I'm very, very curious to see in a couple of years the outcomes from this. It's almost like an experiment, but on the other hand, we don't have much of a choice right now. But I also think when technology change, we're going to see other things also. You talked about, simulation and so on and so forth. Maybe that will change as well in a way we can't even imagine today. Mm-hmm. So I think it's exciting. I think it's very exciting. And being in a new school, being able to create this from scratch, it's quite an opportunity.
Okay. Why don't
I agree.
you go ahead with our next guest, please?
So Lily, you came into an established school with established procedures and processes and so on and so forth. How did you need to change? Where do you see the change is going to be in order for us to move forward?
Well, it is interesting having moved from Iowa, which is a 100-plus-year-old school, to a school who's 16. So we're adolescents at this point. So when you're into this situation, I'm going to take a different perspective. So think about this. I've been here 10 months in Las Vegas. Yes, it's a big gamble. And 40% of that time I've been in the pandemic. So my leadership has been tested, you might say. Next image, please. But when I look at this, and you talk about dental education and post-COVID, we're still in COVID. We are literally still in the middle of it. Our governor still hasn't moved us into phase 3. So when Dr. Nissen talks about CODA, we still are all reacting at the state level, which we're all responsible to. And then even more granular under the UNLV umbrella and how we must be in compliance with our Nevada State Higher Educating Board. So when you think about it, there's 6 months, my life had changed after 6 months. What I thought as a new dean, I had to rapidly switch and had to start thinking differently. So in this, the concerns are there are more positive patients coming along. They're being tested, but we have more testing. So it comes to reason that if you're testing more, you will identify more. And then another caveat on this, as far as demographics, you have to understand in Nevada, Las Vegas has one of the highest levels of unemployment in the United States when you consider our main industry in the hospitality area, although we're rapidly on recovery. Next image, please. So when I think about leadership, it's about different perspectives. So I should have advanced to 3 bullet points, whether that comes up or not. So when you're thinking about perspectives and leadership, you have to put a team together because it's so easy to be able to consider that you have all the answers when you don't. So as you think about this, having the team with backgrounds makes us even stronger. And this was a chance to use every leadership tool I've ever learned to put it together to be able to address the challenges. I have to tell you, it was a great opportunity to bring a cohesive group of people together in a respectful manner. And we're able to weave in the vision we had hoped that I came in with to weave it into this time of change. And change is difficult. We won't even talk about that. Everybody knows that. But in this short period of time, we're able to keep people on track. We turned on a dime to go in asynchronous learning and remote learning, as Dr. Nissen discussed. And if you had to discuss that by committee, it would have been death by committee over 3 years. And instead, within days, we had to switch rapidly to be able to have continuity of curriculum and not cost our students any more grievances, whether it was time lapse, additional concerns with licensure, testing, all these things. So we deployed every known tool we could. So it was a chance for what I would use the word alignment. And I've been accused of using that word way too much. So we're looking at June 29th of going into our dental schools phase 3, which is opening it all up. Right now, we're in very restrictive entry. We have 3 buildings, so it's just not one entry. So making sure everyone comes in, because when you see a patient walk in with a 5-year-old, they are trusting us. They're coming into a safe environment. And in this area, we are deeply dependent and thankful for the public that comes to seek care within our dental clinics. So we want them to have the perception of safety and that we're doing our best. And we've deployed all those same administrative controls and engineering controls that Dr. Nissen has discussed. Next image, please. So when I think about perspectives, and you can advance it through the bullet points, the 3rd bullet point may be blank. I talk about creativity and innovation. If you don't have it, this is not the job for you. If you have any thought about how you want to advance, that's what's exciting. And that's where you need to be able to think clearly, how are we going to reorganize? In the middle of a futuristic thought of me arriving into this institution, I wanted to be able to empower others. This was a chance for full transparency. Everyone needed to know what everyone else was doing. Without that, we could not have a coordinated effort and allow our students some stability. So in the middle of this, having a team member that's an immunologist, another one that's an epidemiologist, some who is an MBA, and an attorney among a couple of dentists, one of which is a public health dentist, all these elements brought together an incredible knowledge base, whereas one had expertise in one area, the other could deploy and understand the science involved. We had to depend on each other because everyone knows throughout this pandemic, it was difficult messaging, whether it was from the CDC, our local governments, our national government. We've all had to use our best judgment. And that's where all those leadership things that you listed on the image of what I've done, it shows that I've been studying way too much. Well, I've used every tool in the toolbox at this point. So bringing together has allowed us to create an education platform that's been a hybrid. It's evident at this point, when you think of our current platforms, we have students clamoring to want to come back in to have that human interaction. So just when I thought they'd love being away, they actually want to come back. So I guess they kind of, I won't say love us, but they're learning to appreciate us a little more. Next image, please. So when I think about our future, I made the messages, and this is another thing, is messaging over and over, whether it was town halls, meeting with individual class leadership, meeting with our campus, meeting with our government agencies, our local dental society, our students. You needed to help them understand that the leadership was doing their jobs. We've never missed a day of work as far as the leadership. We had to show that strength because at the same time, we have emergency services operating. So in this short period of time, up to this date, we were able to screen and manage approximately 1,200 to 1,300 patients, of which 600 we did active emergency care on them. So when you consider that we kept out 1,200 patients from the ERs, we've been able to help our whole national situation or state situation as far as hospitalizations. So we've tried to reinvigorate staff and faculty. And believe me, there are some with fears and some who are compromised, whether we have senior faculty or younger faculty that may be compromised in ways that were really none of our business is health-wise. We had to create that sense of safety and security in a very respectful and organized way. So with that renewed focus on our mission, why we're here, we are actually in a healthcare profession, and that we have to abide by with all due respect. So at one time at another place, I was accused of rearranging deck chairs on the Titanic. And I would argue we are not the Titanic, and this is the time for leadership in which we can redefine our profession and elevate it. So therefore, we must role model and reinforce our messages. We have to really embrace this in a way, not that I enjoy the disease process or what's happening to many of our individuals who lost their lives, but talking with people in the medical profession gives us an idea that we need to be patient and resilient, rely on science, and use our best judgment. Next image. This next image, and the details of which you can worry about later. The key thing is when you talk about the interprofessional collaborative practice, nobody's defined it. Everybody talks about interprofessional education. I use that little nidus where we are locally as at times fragmented systems. This is not original, it's taken from the report. So we've talked about interprofessional education. We have the courses. Well, what does this mean? And that middle point, that is the catalyst. And maybe it's a pandemic such as this in our lifetimes that we can redefine what is interprofessional collaborative practice and actually strengthen our current healthcare systems. Because in the end, we want improved health outcomes for our patients. Believe me, I have two brothers that are physicians. One's in Austin, Texas, and one's in Houston, and they're on the front lines. And they too are working within their systems or colleagues to do what's best for our patients. Next image, please. When I think of where we are now as far as perspectives on procedure-centered care, that we all have been very familiar with. And I'm a prosthodontist, so we still need to learn to be dentists. We still need to make a living from what we're doing, to moving to patient-centered care where we're focused on that. But we're moving into the person-centered care from birth to death. We are part of a patient's life from the beginning to the end, and we should take pride of that. So this is where we need to reconsider our curriculum and bring in that person-centered care concept into the end game. Next image, please. When you think about education moving forward, it's all about the people. You can create structure and processes if you don't have good people in the right places. So we want people to rededicate themselves. And sometimes when the fear was high, you had to say, we're in the healthcare field and we will do what's right to ensure your safety, as well as all those patients who enter our buildings and into our offices. So we're learning that and having the confidence in what we do. And our education and research, boy, are there some research opportunities abound, whether it's simply on perception, whether it's the true science and where do we go from here. And believe me, I work with some great people, so they are already submitting things regarding something to this to federal, looking for federal grants from NIH. And then equity. Equity is also inclusive and diversity. And it's not just of ethnicity, it's of the idea of diverse opinions. But we want to be fair across the board. It's difficult to see, but that image is a picture I took as I was at a hotel in Cape Town. And I looked out the window and there were 3 lanes of highways that were suspended and never finished. And I sat there and they don't even have guardrails. So I hope I wouldn't take a wrong turn and go off the highway. So I sit here and this is where we are, where it feels like we just dropped off when the nation shut down. So what are we going to do when we get to redirect that pathway? Where do we want to be? And that's where I think this is an incredible opportunity for us to maybe define what is truly interprofessional collaborative practice. Our students want the leadership and they're depending on us to help define it. And they have struggled as well. And we know that mental health issues are critical, but we're trying to harness their energy and tell them to use this time to think about helping us redefine our future for the profession. And it's still unknown. I think we were one of the professions that was way underutilized on the front line to be part of the team that helped address so many patients that were coming through. So with that, if you go to the next image, I really thank, and I love being bookended by Dr. Neeson, Dr. Elio, so I feel like I'm in a safe place. So thank you for this opportunity.
No, Lily, thank you very much. I was listening to you, and I think the hardest part at the beginning of this pandemic was to know that you're going to have to stay home for you didn't know how long.
Right.
And slowly you got used to being home. Now it's time to go out, but it's a new turn because it's not going back to what it used to be. It's a new reality out there. You see people in the supermarket and you want to get too close to them. You feel strange when somebody touches you because they're getting out of a shelf something and they touch you with their elbow and you feel like, there's something really strange there. So it's really going to be a new reality there. And with these thoughts, before we go to our next guest, I would like to introduce a short video from a sponsor that has been with us from the very beginning, somebody who trusts this production and all these crazy ideas. And I have nothing but thank you for them. So let's run the next video, please.
Protege a tu clínica y a tus pacientes. Conoce la fórmula de O-Radical de amplio espectro como desinfectante orgánico de superoxidación que elimina bacterias, virus y hongos desinfectando superficies. Desinfecta tu consultorio, equipo, sillones, instrumental quirúrgico, rotatorios y cucharillas. Además, no mancha y no guarda olor. Protégete y protégeme. O-Radical, el mejor amigo en tu consultorio.
I really want to thank Ideas Dentales because they were sponsors from the first program. Mike, it's time for you to introduce our last presentation for tonight before we start this interesting debate.
So Dr. Eliav from Eastman and Rochester, again, his director. He's been there for, I think, 7 years now as a director of the program. And it's interesting because it is a postgraduate program with, I don't know, Eli, how many postgraduate students do you have right now in different disciplines?
160, and we have 200,000 visits a year, patients visit.
So with that in mind, I think you can tell us a little bit, number one, about the experience of running that postgraduate program, which is very different from obviously what Linda and Lily are coming from, and how this is going to affect now what you believe is how it's going to affect the future of dental education in postgraduate training. Because I presume in postgraduate training, the patient interaction is going to probably be much, much more than it can be, or that we might be able to avoid a little bit in pre-doctoral programs. So please, Eli.
Thank you. It's a great pleasure to be on this panel, and thank you for inviting me. I will not be able to see the slides. Okay, so I'll take it from here. No problem. Our perspective is a little bit different also because we are already in phase 3. We already returned to work. We don't have that privilege of planning our building, and we even don't have the privilege of planning how we come back to work. So I'll try to share our story from what happened here and how we went through that and coming with solution while we in motion. Next slide. Oh, it's here already. Disclosure, just go over it. I think that the association to some industry, but nothing is related to the presentation I'm going to give today. Next slide. Those of you who do not know, we are in Rochester. Rochester is the blue circle here that you can see on the screen, south to Toronto and north to New York and Philadelphia. Next slide. Rochester is a beautiful place, but if you can see in the bottom slides, it can be very cold sometimes. And my background, if you could see it during the presentation, it's not from Rochester, it's from my hometown in Israel on the beach in the Mediterranean. Next slide. Eastman Institute for Eye Health is, as Michael mentioned, is postgraduate education institute. We have very high-level research. We have 11 programs that are approved by the Commission on Dental Accreditation, but we have a huge clinical enterprise with community service with about 200,000 visits a year, and the community is relying on our services. Next slide. What we had in Rochester is a little bit strange because we almost had no COVID-19 exposure or surge. We had about 3,000 cases, and those numbers are from Friday, so maybe we had a few more since then. We have 250 deaths, and we were waiting for the surge to come, and it may still come, we don't know. It may be related to the fact that it's a very rural area, a spacious area, so we really do not know. We've been preparing, we stopped everything, any elective procedures, and we're still waiting for the surge to come. It didn't come. Next slide, please. From the timeline of what happened here, I'll try to share the story and how we approach the education. At some point in the middle of March, the governor of New York announced that non-essential elective surgery can be done, and especially, and he has a special statement about dentistry. Dentistry cannot do anything but emergencies. So we all had to stop doing dentistry. We had to close all our clinic. We left only one clinic in our main building, but something that we did different is we kept all our residents in place, and they are those who provide the care. Our philosophy was that they are almost specialists, they are almost faculty, and they should need to how to deal with it. To approach the potential problem, we divided them into groups, into teams with staff and faculty, and they rotated. We had for several days one group, and for several, and they were replaced with another. So if in case that was exposure, we could have another team that can address the need. And like that, we worked for about 2 months. And in June 1st, we came back to full dental treatment. About a little bit earlier, we started having a treatment in the OR, but because the hospitals were allowed to stop seeing patients for elective surgeries. Next slide, please. So our volume went down from about 750 visits per day completely to 100. In the beginning, it was about 100. But with time, we had more and more patients coming for emergencies. So we saw more than 5,000 patients from 48 counties in New York, because no one else was providing those cares, that came to be treated in our facilities. We had, next slide, we had to face several challenges. One, our building is not that big. We cannot rebuild the building. I mean, that's what we have. We had a problem with social distancing. We had in the beginning problem with PPEs. We couldn't get enough N95s. And the patients, the faculty and the staff and the students and the residents were very stressed. And like I think that Lily mentioned that as well. We had to deal with it. So we had a team that mental health that helped us, and we had a nurse on board that helped the resident dealing with those stresses they've been through. We had to make the patient to trust us, because they came with pain, but they're not really trusting. Am I safe when I come here? I heard the dentistry is very dangerous profession. We had to learn how to screen the patients and the staff and the faculty. The first thing that the medical center developed was it's called Dr. Chatbot, that every employee in the morning before they come to work, they have to answer several questions. If one of the questions is positive, they are referred to call a center of nurses, nurse practitioners that guided them should they come to work or not. If all answers are no, they can come to work. So the screening was done through an app before people came to work. And you can see here in this slide, please move to the next slide. You can see in the left side of the slide that when people got in, they had to stop and be screened, and temperature was taken for all the day. And everybody that got into the building, not all the patients. Next slide. The stress or anxieties that people went through was related to the fact that we really didn't know much about that virus. And people were concerned, are the PPEs that we use good enough? Is an N95 good enough? In the beginning, we didn't have N95 for everyone. What is the mode of transmission? Is a patient that is asymptomatic, can they transmit the condition? Should we test every patient? The medical center couldn't, even if we wanted, if we thought that we couldn't test everyone, because we're not enough reagent in the beginning to test everybody. Now they can, but I don't think that there is a need to test them. Next slide. So when we came back to work, we didn't have time to design and plan as much as we could, and we tried to rely on any evidence that we can have. And there is the CDC guidelines and the ADA guidelines, the New York State guidelines, but we tried even to look at Cochrane review, recommendation that they gathered from all around the world. And I think that the bottom line is there is limited scientific evidence to support any of the recommendations. We talk about social distancing, we talk about UV light, we talk about HEPA filters, we talk about PPEs. We don't have data to show that it really works. Next slide. But there are things that are already given. I don't think that will go back from the N95s. All the residents, all the dentists will work with N95. So prior to COVID-19, we have level 1 mask, eye protection, goggles, gloves, and isolation gowns. And when we started working, and Michael was among the leaders in treating patients with HIV, some of us even didn't use gloves when we started working many years ago. And I'm sure people are smiling because that was the case. So we moved through the HIV time to much better protection, but now we're moving even one step further, and we're having N95 masks, face shields. Very difficult to work with face shield. Our residents are working with N95, level 3 mask on it, and face shield. After they finish a treatment, they need oxygen because they're really they cannot breathe during that phase of the work. Next slide. So another problem that we have, and it was mentioned by the previous two speakers, is what are the difference between private rooms and open space? We are lucky. We have only 36 dental units in open space. All the other units are in private rooms. How do we deal with that? And we need to be creative. we'll go back to the open space in a minute, but one thing that we did a lot during that time is teledentistry or telehealth for patient pediatric dentistry, oral medicine, orofacial pain, urgent patient, emergency patient. Before they came to the building, they had the opportunity to have a teledentistry appointment with one of our doctors to decide should they come or should they not come. Another thing to solve the problem of the social distancing, maybe we'll be able to add part of the building, but what we did, we got one of our Smilemobiles in front of the building, we built tents, and people can wait there and being screened in the Smilemobile, and that reduced the level and number of patients that we had in the building. I don't know how this is going to work in the winter in Rochester, but we will deal with that when the time will come, or we'll plan before. Next slide. So what is happening now? The next class of residents already arrived on June 15. All lectures and seminars, like mentioned by Lily, by e-learning. Everything is by e-learning. They did the orientation online. We extended our clinical hours to be able to catch up because it takes longer to see a patient. We need to wait 15 minutes before we can even clean a room. So we extended the hours. All the lectures are saved on the server, and they can see them whenever they want if they miss the lecture. So we're working now from 7 o'clock in the morning till 9 in the evening in some of the clinics. We work Saturdays. We have shifts. For example, the orthodontics department, they're having on Monday, it's the first year program, the first year students are in the clinic, and the second year are having lectures online, and they switch on Tuesday and so on. And this is the only way they could solve the problem because their clinic is not big enough. All interviews for next year students are done by Zoom. So we have videos to show them how the area looks because they're not even allowed to come to see the Rochester or the clinics that they will be working in. Only hands-on and clinical teaching allowed in person. We have daily screening using the chatbot, and testing is based on procedure and patient medical status. And I will not say anything more about it now because I'm sure that questions will come, or I assume that questions will come about that. So next slide. The same like Lily and Linda, it's not the first time that we see a virus or infection. We treated patients with HIV, hepatitis C, influenza, tuberculosis, you name it. And right now, this virus, for some reason, allowing us to do things a little bit better, and maybe we can improve the way we see patients, the way we protect ourselves. But it's not new, but it is an opportunity, as has been said before. Next slide. So what can we do? The best thing we could do if we could eliminate the virus with vaccine or herd immunity or a miracle, but this is not happening yet. This may happen hopefully within a year or so if we have a vaccine or not. PPEs, I think that we got to the maximum level that we can. We cannot go, and I think one of the infection control people from the medical center, we brought him in to see what we're doing, and he said, your students are heavily guarded because they were protected with all, and difficult to work. We cannot add to it anything. Administration control, we can improve the patient flow, the time, and all the things that we learn by working, because how we improve social distancing, how we make the clinics efficient. But engineering control, what Linda mentioned in planning their school, this is something that we in our old building, we need to find a way to solve it. And we found a way with some engineering study that if we add certain air handlers, we can improve the air flow, but we can even have the open clinics, we can build like an air tunnel that the air is going from up, down, and to an area that is going out. So the rotundas, and we need to see how much it's going to cost, but that will make the rotundas, our open clinics, the safest place in our building. Next slide. So what is the future? Well, what do we need to do? We need to continue emphasizing the need for better PPEs, and I hope that the cost will go down, because right now it's increased in so far for us in 25%, but it will be more than 25% cost for PPEs compared to what we paid before. Screening and testing. Aerosol, we need to find a way to control aerosol, and there are so many devices in the market that you can have intraorally, extraorally, but there is no data to show that it works. And we are doing several studies in Eastman, and we build a model to test those before we invest the money in buying the devices. We need to know which one of them is working. We need to they have better dental clinic design, and Linda has she's fortunate. She can do it now. For us, it will be a little bit difficult. Our building Eastman is 106 years old, 105, but the building is a little bit younger, only 40 years. We need to do more telehealth. That's how we're going to do it. We need to have it as part of the training. Telehealth should be part of the training of our residents and our students. Not everybody that used to apply for dentistry will apply now for dentistry or specialties, because we can see the stress. Some of our residents could take the stress better than others. Those that cannot take the stress, when they go out to their private practices or anywhere else, they will not be able to do it. And we need to do more research. Dentistry can be a pioneer because you know about the symptoms. It's known that some of the symptoms the first symptoms are related to our area: taste, smell, and hypersalivation. So I think that I'll stop here and we'll take it from here for questions and discussion. Oh, there is the next, a few slides. The last slide, maybe go to the last slide and I'll show something. One more. Few more. Okay, here you can see, I think that the people that cleaned our building, that they're doing more than ever. We're cleaning the elevators, all the door handles, everything again every hour. So that's another investment that we need to think about. This is something that in the past we were okay with twice a day. Now it has to be done on a regular basis, every hour. Okay. Thank you.
So this is very interesting, and I think we did a great job, Jaime, in selecting these three speakers for many, many reasons. First of all, obviously, because of their insight, expertise, and their knowledge. But Linda, who is fortunate in many ways, will be able to create her own culture and start from scratch. Lily, who comes in to a culture that needs to change and need to be, as you mentioned, resilient, and I could probably add being more adapted and flexible than probably ever before. But you also mentioned that you now can utilize the expertise of people very differently, the immunologist, even the lawyer, and so on and so forth, and bridge gaps that probably were not there before. And now people can see how everything sort of fits together much better than ever before. And then Eli, who is a scientist, and I don't know how many times he said from a scientific standpoint, does the stuff work? We are spending enormous amount of monies now on infection control procedures, et cetera, et cetera, et cetera. What I'm looking at, coming from a little bit of an epidemiologist, scientific, curious mind, is I've never seen any reports on clusters of dentists having been infected with COVID-19, even from countries that never shut down the dental clinics. So they continue to treat patients, although COVID was around. They used the same infection control procedures as they did before. If I took that as a scientific evidence, do we actually need to go to the next level? Now, I would never dare to say something like that and say that should be our rule, obviously. But if we want to be truly scientific about it, maybe we're exaggerating. Jaime, when he came in here, he said, he practiced dentistry and it's today, and he was so tired. And I think part of it, Jaime, is probably all the stuff that you have to put on and the mask and how warm, how hot it is, and so on and so forth. Maybe you can have some comments as well when it comes to how it is actually to practice dentistry today.
Or maybe I'm getting used to how fun it is to be in home, but it's hard to be home and be addicted to adrenaline. Before we go into the questions, Michael, we're going to have to see, we have a short video where you can see, if you go to ID Academia YouTube channel, you can watch all the previous programs for everybody who's watching us from the United States or everywhere else where they want to see all our programs in English. They can see this. You see, it's incredible, but we had a lot of people in the past few weeks, So, I have a lot of questions, but I don't know. I really don't know where to start. I have a lot. So let me just.
Jaime, you know how they say, how do you eat an elephant? So when they shut down, you just start one little bite at a time. Just
Well, the first one will be, has been also an opportunity for preventive dentistry, no aerosols dentistry. And I don't want to talk, it's not politically correct to say that we help people lose their teeth eventually, but everything started with a small amalgam, which wasn't that small, and then became bigger, or the tooth cracked, et cetera, et cetera. You know the pathway of an amalgam, but will we need less dentists in the future? Silent in the room.
I don't know that anybody knows the answer to that, but we certainly need dentists to provide primary preventive care. And I think the use of teledentistry, it's been around for a while, but now we see people using it. The fact that and I think teledentistry makes it more accessible, makes dental care more accessible. That people can, talk to the dentist through their computer, show them, I can just imagine, show them their teeth. Do they need to come? Don't they need? What do I do? Is it, a child that has a problem? So I think teledentistry is great, but I think, Jaime, you're absolutely right. This has focused on aerosol. We've never talked about aerosol generating procedures and non-aerosol generating procedures. That's a new language in dentistry. And because it's a new language, it allows us to rethink the procedures that we do and all of the preventive procedures that are non-aerosol generating that actually make a big difference to the patient. So I think you have a very good point.
Can I also add to that? Jaime, you brought up a very important point here about prevention. So Linda, Ellie, or Lily, this also gives an opportunity for more patient education. We can actually have an opportunity now to improve oral health literacy that we never had before. Is that something we should focus more on then in the future for dental education?
absolutely. I'm going to chime in and tag along with what Linda was saying about teledentistry, telehealth. And I'm in a state where Iowa had rural counties, but there were counties that were populated. I'm in a state now that is called frontier medicine. It's true isolation. And so how are we going to get to those people? How are we going to address their needs? And I think the education portion could be through telehealth. You throw in an intraoral camera here and there, they don't have to pull it back their cheek, Linda. They'll simply show it to you, through an intraoral camera. So there's some possibilities here. But I would say you still need dentists. I still think dental practice is an incredible profession. And you're seeing some rebound. People will be making choices this generation, whether they want to continue. And this knocked people for a loop. Nobody was ready. Like I said, we kept working because you can't afford not to work. There were still needs. But we still haven't been able to create programs that are going to entice our young practitioners to go into these rural, if not frontier areas to provide care.
I think,
Ellie, I have a question for you. You mentioned that you had the dilemma, if I understood correctly, about testing or not testing. So putting a few questions together, do you think testing for COVID will become normal or even mandatory? And when you tell testing, when we think of testing, does that include the patients, the co-workers, and in a school would mean all the school personnel? And how, thinking that I've been tested today and I can be in a false positive, I can be in a false negative. What are your thoughts about what's the future of testing as long as we don't have the miracle cure or vaccine?
Yeah, one before I go to that, then they will need dentistry, but it will be a different type of dentists because people will live longer with the teeth in their mouth. There'll be cancer survivors. People with intellectual development disabilities live longer. The lifespan is now 65 years old. So dentists will be needed, but it will be more educated dentists that can treat patients with complex condition, and that's what we should focus on. But we're going back to the testing. The testing, the way I see it, I mean, as you mentioned, you can do the test today. Within 2 days, someone can be infected again. In our medical center, the healthcare providers' level of antibody, people with antibodies, is lower than the population that are not healthcare providers. So the testing is for the patient. It's not for the provider. We are protecting ourselves with 100 layers of PPEs and air control and other things that we use. So the testing, the decision whether to test or not, is based on the patient. So if we have a patient that we know that we have a very invasive procedure, it's a patient that has medically complex condition, those patients I will test them. But not every patient. There is no reason and no justification to test every patient. And we in dentistry don't have one surgery and they go home. They are coming once a week, twice a week, once a month. You cannot test them every time. It's not a pleasant procedure to stick that thing and take the tissue or the sample. Unless we will have a chairside procedure that will be very quickly, saliva or finger, and then we get an answer within 30 minutes, it's okay. We used to say that the patient can be tested up to 3 days before the procedure. Now we're saying 5 days. And tell them, okay, after you do the test, stay home. So they are in quarantine now for 5 days. I mean, that doesn't make sense. We are protected and we're doing the test for the patient. That's my philosophy. I'm not sure that everybody agrees with it.
Michael, what do you think?
Oh, I didn't want you to ask me that. I think the problem with testing is how to interpret the tests, because depending on the prevalence in the community, the test results are going to be very, very different because the sensitivity and specificity of the tests we have today, meaning it's false positive and false negative, so it's going to be very, very different. Which means if you as a dentist are you actually going to use a test, you have to know how to interpret the result. That's number one. And number two, you need to know what to do with the results. I'm going back to the HIV epidemic. I had a clinic in Philadelphia where I treated a lot of HIV patients, and we only had HIV patients. And people said to me, "You're crazy. Why do you treat all these HIV patients?" I said, "I'm the safest dentist around. I assume everyone is HIV positive. Those who don't assume they're HIV positive, you are at risk because they're not going to tell you they're HIV positive, and you're not going to take what type of precautions you think are necessary." I think this is going to be the same thing. COVID-19 is going to be endemic, and we have to treat everyone the same way. I don't think testing is going to help us in any kind of way at all.
Okay. Do you have another questions, or should I go ahead with a huge list that I have in front of me?
No, I think I think my biggest question is, and I think all three of you avoided it very cleverly, is can we expect our new graduate students, postgraduate students to have the same patient requirements as they had prior to COVID?
No.
We talked a lot of simulation and et cetera, and we can do a lot of different things, but the tongue is not there when we do all these type of simulations. Should we reduce the requirement of dental students when it comes to treating patients? Because that's the ultimate, obviously. And Linda, I'm looking at you because CODA will be probably the one that's going to make some kind of determination to determine the competence of our graduates. So how do you see the patient requirement? Is that going to change at all?
So I think Ellie provided some good insights when he said they extended clinic hours. You know, traditionally, our clinics have been 8 a.m. to 5. Well, if you can only fill the clinic with half of the students because of the requirement for physical distancing, then you've got to increase the number of hours. Again, CODA only holds the school accountable to its own standards. So the school needs to assess how the student is competent. And if they need more clinical time, then we've probably got to extend the hours. And, you know, I heard Ellie say they're working at night. They have Saturday clinics. That may be, you know, some of the approaches to making sure students have sufficient clinical patient experiences so they can develop the competencies.
Does that mean we need more faculty?
That may mean that we need more faculty if we're going to work longer hours. Yes, it may.
So dental educations could be more expensive.
Yes, that could be what that means. Or we partner. We partner with dentists, perhaps in the community, with community health centers, with hospitals. You know, there's 100,000 dental practices in the U.S. You know, to the extent that they may want to be involved in dental education, we could, you know, dental education could partner with those in private practice. We haven't really done that to any extent. And I don't know if schools have tried it and it hasn't worked, but that may be another new partners. Think about different partners that we would have.
Well, I think the school down in Arizona, Jack Dillenburg's dental school, actually did that to a large extent, actually. So I think some dental schools have tried it.
They've done it. They partnered with community health centers throughout the country, and in fact, at Kansas City University College of Dental Medicine, we are planning for a 4th-year program that's community-based. That we're going to partner with community health centers, federally qualified health centers, and other dental delivery systems, so that we're planning for a class of 80 and have the students spend 12-week rotations out in the community.
So more dental faculty, more expensive dental education, more student loans, higher cost for infection control procedures. Is dentistry going to be too expensive in the future?
You mean it's not now?
No, I mean, are there going to be fewer patients that will be able to afford dentistry? It sounds like it's going to cost a lot of money.
Well, you have quite a loaded question, Dr. Glick.
Yes,
You really loaded that. First of all, let me just backtrack a little bit. When you say, are they going to be needing patients? We want them to do dentistry. We want them to do as much dentistry as humanly possible. And we are technically the clinic of choice for those who lack access to care. So we are trying to make it affordable and working with partnerships to make it happen, whether if it's at an FQHC or being able to take Medicaid and negotiate that. Now, the thing about testing is how do you make it calibrated in such a way? So having a lot of community faculty is very difficult to calibrate. And now the commission is saying, so how do you validate your calibration? So there's a way to get students to have a lot of experiences as much as possible, and then maybe have a type of a simulation to give them the similar test environment that may happen. But remember, in all of this, we still have live patient exams on clinical licensure. So we're battling, we're getting hit from both sides. As far as cost, it's incumbent on us to use our resources carefully, very carefully. And we are going to extended hours. We have to. The class of 2020, a lot of schools accommodated and got them graduated. My concern is now the class of 2021, because they're the ones we're making sure, do we have enough hours? Do we need to open the clinics? Do we have to have 4-hour appointments? Should it be every 3 hours and 3 shifts? So we're looking at every possible solution. And the state is just telling us we're going to undergo a very severe budget cut. So it's not like you can go out there for a whole lot more faculty. So
I think
Let me bring in Ellie, you wanted to talk?
I just wanted to add one thing.
Go ahead.
I think that the solution, it's very difficult. I mean, it's very expensive now, and it's very busy schedule that the student have. But the only reasonable solution, and I know that I can say it and it will not happen, mandatory AHD or GPR, because this is the time that they can get experience really hands-on. They can learn on simulation and other things, but the time that they do the work is AHD and GPR. And that, I think that will need more GME funding, and they will need to do lobbying for that, but that's probably the solution.
You know, I think you're a mind reader. I was going to tell you the story. When I went to UConn in the late 70s, there was this idea of our dean, Harold Le I was never able to pronounce it correctly, that the best way to finish dental school is to have kind of a GPR. And he built this program called Family Dentistry that I attended as a resident. And on the second year, we had an experience that we had to go to a family medicine, family dentistry clinic in Hartford, in a very populated area. And it was great because we, the dentists, learned a lot of medicine. The problem is that the MDs over there didn't learn anything about dentistry. They just didn't care. And that brings us to my real question. Is it time to bring this wall, not the wall between Mexico and the US, Mike, but the wall that exists, or the dichotomy that exists between dentistry and medicine, and how much it could be accomplished by interrelational, interprofessional relations, but eye to eye, not like, medicine has always looked down on dentistry and is like, oh, okay, come on, here they come, the carpenters of the mouth. But isn't this, as we said, a time of opportunity? So do we see dentistry going as a medical specialty? Can we really go together with the MDs in the future and have certain classes together like it happened in the late 70s? And believe me, I took a lot of advantage of that because I learned a lot of things I didn't know. Although I have a father who was an ENT, so medicine was brought into me, like, even if I didn't want it to. But what do you think about it?
I think that we have a leader in this area on the panel here, Michael Glick, but I think that we should. We have no choice. And Michael and I went to a school that we did 3 years medicine and only then 3 years dentistry. That's the system there. But we have to. And it's a battle that is an ongoing battle. We are embedded in a medical center. I think that we are respected. People take us very seriously. But when this COVID outbreak started, we were not around the table in the beginning. We had to push ourselves to be around the table. They admitted that they should have done it before, but it's an ongoing battle. And we need to show that we know medicine. And you know what? Dentists know a lot about more medicine than they think. And we need to show that we do. We need to be available to physicians whenever they need. There are things that we are the only one that can do that. Did you see, I don't want to say bad thing, but we are doing locals anesthetic better than any other profession in the medical field. So it should be our job to try to push ourselves. And I see a lot of schools and friends and peers, they're trying to avoid it. Oh, I'm only a dentist. I'm doing what I'm doing. No, you're not only a dentist. You're a dentist. And you're the only one that knows how to do what you're doing. No one can do better than you. And try to ask a general surgeon to do an implant and full mouth rehabilitation. They can't. Okay, they can't. You need to have the skills. And we have the skills. So we need to look in the eye, stop having that inferiority complex, and show what we do and offer our services.
Yeah, let me just add one to that. I used to tell my students, we are healthcare professionals that happen to be dentists.
Sí, ya te escucho.
And when the COVID-19 vaccine comes, in order to distribute it in the population, Ellie, to your point, if we can do that with a local anesthetic, we can certainly do that. The dental professional workforce should be able to provide vaccinations as part of our healthcare services.
Today, I think it's only Oregon that allows us to do that, although every pharmacist in the United States is allowed to do it.
That makes me crazy. Yes.
They do it mandatory with hepatitis B, right?
Mm-hmm.
No, but now Linda talking about the dentist actually performing the vaccination immunization.
Okay, can we do it?
We should be able to. I mean, we're going to want to get the vaccine delivered to the population quickly. Well, if you've got 120,000 offices, that are essentially medical facilities that, with a workforce that takes a very good head and neck anatomy course in general anatomy, probably much better than pharmacists, we could be capable of helping administer the vaccine.
No, and then, we inject people for 20, 30 times a day. So, yeah. I inject myself. I have a better hand than the other people. Listen, there are more questions. There is one, about the test. I tried to put all of them. There is a lot of questions around the N95 masks. I'm telling you what my feeling is. I think that we should use it when we use aerosols. And but when you finish the aerosol, do you think you can go back to a normal face mask? A lot of questions around the mask, but it's horrible to work with those things. You really need the CPR afterwards.
Well, part of the problems when you're talking about removable prosthodontics and dealing with prosthetics, it may not be an aerosol, but it's a fine dust, almost a light mist. So it's very hard to think that there's nothing in the air. And that's why we're starting to think everything you touch and somehow run a rotary instrument generates into the air unless somebody is right there, which is why in the beginning, as we're bringing in students, every student will have an assistant. And that's why we have a very controlled entry and air handlers and double checked our air conditioning systems on their filters and the exchange. But I kind of think we will go, as Michael said, we treat everybody as though they're COVID positive. And then we have more assurances for our own safety.
Because COVID is in the air?
If you're running something, it says transfer.
No, it was the real song is "Love is in the air." I just checked for "Cove is in the air."
But you know, when you said that, the fire goes off behind my head, so I don't know what's going on the video. Looks like my hair's on fire. So anyway,
Yeah, that's CNN. That's not us.
Okay. Thank you.
Some people, this is a strange question. How would you see the future? Is it going back to the past of preventive dentistry?
We should never have left it.
Yeah, I guess. There are a lot of questions about what to use in our handpieces, if we can use certain things in the handpieces without ruining the handpieces. Is there a special platform that you use for online education, or you use Zoom or the regular webinars?
We're using our learning management system, which is Cisco WebEx. They're finding at the time, not that we're pro or against Zoom, but the university system is trying to protect us and use that for security reasons. So,
yeah, our university is using LifeSize, using a platform called LifeSize for a similar reason. We're also starting to use Zoom because the small breakout rooms appear to be easier to use.
Mm-hmm. We use Zoom for lectures, and we record all the lectures, and they're all on Blackboard. And now we started working on building classrooms in Blackboard. We have some of our faculty that are taking and took courses in the School of Education, how to build an e-learning class. It's interesting. We started in just recording and giving it on Zoom, and now we're building a virtual class, which is way beyond what I know, but they look very enthusiastic and they enjoy doing that. So I'm looking forward. Each one of those faculty that took the courses is working with the course director to try to help them develop that virtual class. We'll see how it works. I'm very optimistic though.
So the skill set of the future faculty member is going to be very different than the skill sets that we have today.
Yeah.
think of what we need on our staffs. IT has elevated itself to the top need. So when you have somebody records a lecture with video, the amount of memory that takes is huge. So sometimes students will have to see one lecture in 3 segments. So voiceovers are different levels of memory. The server capacity, all of a sudden our quiet IT guys at the help desk are actively working longer hours, and we need more of them. So
let me also give you a little bit of a future caution here. These videos and everything can be altered by someone, somehow. And I think that's something we haven't experienced yet. But I'll bet you anything that in the next couple of years, you're going to have students figuring out how to alter these things, even faculty altering things. And we're going to have some huge problems unless we get some security on and be able to detect altered recordings.
Yeah, or else we're going to find our slides in somebody else's presentation.
That already occurs. It already occurs.
Let me ask
We
you
were
one
discussing
thing.
this yesterday during the rehearsal. Listen,
let me
we're
ask you
almost
that.
an hour and a half on the air.
Jaime, I have one very important question to all three of you. All of you have mentioned teledentistry. Do we actually have the system today to be able to have the privacy, the confidentiality necessary to truly implement teledentistry today?
We're doing teledentistry.
This may be actually a social justice type call, because not everyone even has the internet nor even a simple laptop to access. So when you talk about cities should be looking at infrastructure that everyone has access to the internet. This has exposed it dramatically on what we need. So safety and security, oh my gosh, HIPAA abound. Who knows what's going to happen? So
So I think we have to be very careful. I think teledentistry is wonderful, and I think it is the future. I'm not sure we're there yet. Linda, I think I interrupted you.
Well, no, I was just going to say my understanding was that CMS, the Centers for Medicare and Medicaid Services in the United States, has approved teledentistry for Medicaid and Medicare, which it had never done before. And it had approved it for the teledentistry being done in the patient's home. So, the government, the U.S. government had concerns about, safety and privacy as well. But because of the pandemic, they've waived some of those concerns and allowed the use of teledentistry. But I think to Lily's point, this epidemic has really brought out the difficulties, the disparities in our society that already existed in the U.S., but we weren't aware of, or we were aware of it, maybe we chose not to deal with it. But now you're seeing it to a much greater level, not only in who gets the disease and who dies from the disease, but who's working in the infrastructure, putting those individuals at risk, and then access to healthcare. And to Lily's point, having access to, a computer at home with an internet line certainly makes a difference in terms of access to telehealth.
Yeah.
Another point with telehealth is whose license will need. I mean, if we have someone from a different state, you need license. It's my license in New York, or it's someone else in I don't know where. But we use teledentistry in various ways, and we're trying to expand it for years, and we couldn't. But since Zoom was approved by Medicaid, Medicare, we've been able to expand it, and it's working through e-records. So it's working through the system. But what we did for years, we have locations, several places, and you're familiar with Southern Tiers, a little bit more rural area. It's a 2 hours, 3 hours drive, 4 hours drive from where we are. And we have a nurse there with an intraoral camera and a computer. And the kids are coming and we screen them. What we saw is that the compliance before we had the teledentistry was about 20% of them continuing the treatment. Now it's 93% of them are coming for treatment. So we improved the compliance, even that, nothing beyond that. And we're going, if you're familiar with the map, all the way to Watertown, and this is, 5 hours, 6 hours, and we see the kids somewhere in the middle. We drive to a different place of Syracuse, and we see them there. It's connecting people to telehealth. For oral medicine, we're doing, for oral lesions, we're doing it for all over the country now. For oral facial pain, the same story. But before they come to emergency, we found that very, very useful. People were so scared to come, so they had a doctor to talk to, and nothing more. They just, yes, you should come, or you can wait a few days, let's see what happened, let's talk tomorrow, and that works. And you don't need a lot of security with that kind of appointment, I think.
Jaime, I think it's been
my microphone was off. Sorry. We're going to go to a very short video of our sponsors, and we're going to come back with the final round where each one of you will give your final comments. So please run the video.
OrthoGuard es una línea completa especializada para quienes usan aparatos de ortodoncia. Cuenta con 3 productos de uso diario que ayudan a prevenir las lesiones de mancha blanca en los dientes. El enjuague bucal especializado Colgate OrthoGuard, con una fórmula revolucionaria en el segmento de los enjuagues bucales, le proporciona a los consumidores una efectividad terapéutica en el tratamiento ortodóntico y en pacientes de alto riesgo de caries. Llegamos a los espacios irregulares generados por la adhesión de la resina y el bracket, previniendo la desmineralización del esmalte hasta un 58%. Libre de alcohol, sabor agradable y de uso diario en personas de 6 años en adelante. El nuevo gel dental especializado Colgate OrthoGuard, con 5,000 partes por millón de fluoruro de sodio, ideal para personas en tratamiento de ortodoncia y o con alto riesgo de caries. Revierte 3 veces más las lesiones de caries inicial y proporciona hasta 40% mayor reducción de caries contra una crema dental regular con fluoruro. Es seguro y se recomienda usarlo diariamente, una vez al día durante el tratamiento ortodóntico, indicado para personas de 6 años en adelante. Durante el tratamiento de ortodoncia, los cuidados de salud bucal exigen mayor atención. Los brackets y alambres ortodónticos pueden impedir una buena higiene bucal. Por eso Colgate ha creado el cepillo dental especializado Colgate OrthoGuard, con cerdas multinivel, indicado para quienes usan aparatos ortodónticos. Gracias a su forma en U, cubre toda la superficie del bracket, mejorando el efecto de limpieza en la encía, dientes, alambres y brackets. Las cerdas externas en forma de espiral eliminan la placa dental en la línea de la encía, proporcionando así una mejor sensación de limpieza en los tejidos bucales. Y a su vez, las cerdas internas auxilian en la limpieza alrededor de los brackets y alambres ortodónticos. Sus puntas de 0.01 milímetros pueden limpiar pequeños espacios, proporcionando una mejor limpieza de la superficie de los brackets y alambre. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
Well, it's incredible that we've been talking for 1 hour and 32 minutes, and it just went like this. So I would like you to make in 1 minute your final comment before we have to close the program. Should we start with you, Linda?
Well, I want to thank you for the opportunity to be part of this panel. And I would just like to thank you for bringing education to the community. We're all learning from this pandemic. This pandemic has required us to do things very differently, very quickly in dental education. I think we will take some of these changes with us to the future. And I think it's basically identified some serious issues within our society. And as we get back into the clinical aspects of dental care, I think it's going to allow us to rethink how we provide care. The AIDS epidemic in the 80s prepared us for a bloodborne pathogen. Preparing for COVID-19, we're preparing students to take care of patients there may be a respiratory transmitted pathogen. So I think that the future is unknown. It will be different, and hopefully we will continue to educate our students to recognize that they're health professionals, that they are to care for the whole person and to improve not only the patient's oral health, but their overall health as well. So thank you for this opportunity.
Thank you, Linda. Lily?
I'll echo all the thank yous, and I'll send you my thank you notes after this. But when you think I moved from a state that winters can be several degrees below zero to a state that's several degrees above 100 degrees Fahrenheit, the range of possibilities, I will remain optimistic. We have over 6,000 graduates in the class of 2020, and they've survived this. And those are the ones who are going to make this happen for us in the future. We'll be the ones being shuffled in to get our teeth cleaned or removed or whatever is required. So I'm optimistic because they've learned from this, and they're also going to have a better balance because they're the ones who experience the mental health issues, the challenges among their family, friends, and that's why I'm very optimistic about this and about leadership and helping us move forward. So thank you.
Ellie?
I think that this virus created a lot of challenges for us, but also lots of opportunities. And we saw today 3 levels. We had to move to do something, and we're already working. Linda is preparing, and she has time now. She can do it the best we can. Lily has a little bit more time than us. I think that if we can share what we've been through and the mistake that we did, and other can use that knowledge and take it to their area, that will be wonderful. But dentistry will be different. The students will be different, and if we'll be able to think and look for data and for evidence, we'll be able to build maybe a better curriculum and better dentists that will be better than us, that will be ready for the next generation of viruses. It's not the last one, I promise you.
Yeah. Mike, before you and I say goodbye, we're still going to come back, but do want to thank a lot of people, especially our translator tonight into Spanish, Dr. Samantha Arispe. She's been doing a great job for 5 weeks now. Thank you, Samantha, for always being there and taking care of our Spanish-speaking audience. I also want to thank the production. The production is in León, Guanajuato, Mexico. And as you can see tonight, through the magic of technology, we had Michael Glick from New York City, Eli Eliav in Rochester, New York, Linda Nissen in Kansas City, Lily Garcia in Vegas. And thank you, Lily, because whatever happened in Vegas, now it's going to happen everywhere. It's not going to stay in Vegas. And we also want to invite you to our next program. It's going to be next week, next Tuesday. The program is going to be in Spanish. And it's going to be a mano with a very interesting guest, Carlos Glad. And we're going to talk about change or innovation. It's just going to be a mano, a one-on-one, me and Carlos next week. And we want to thank our sponsors as well. And Mike, do you want to say something before we close off for tonight?
No, I just want to thank the three of you. I'm much smarter now than I was an hour and a half ago, and I've got many, many more ideas. And I think that's what it's all about. So thank you for enlightening us. Thank you for sharing your experiences. And I hope we can continue to work together in the future, because it seems like this combination of ideas coming from different perspectives is really what we need in the future. So really, all my gratitude for you, Linda and Ellie, staying up so late, and Lily for probably took away your dinner time here somehow out in Las Vegas.
No, thank you very much. And for all of our audience, wherever you are, thank you very much for listening to us, either in this live broadcast or this will stay in Spanish in ID Academia channel in Facebook. It's going to stay in the original audio in English in YouTube Live. So until next week, we all see you. Thank you all very much.
Thank you.
Bye-bye.
Bye-bye.
Si te lavas bien las manos, lograrás prevenir con jabón y un buen tallado tu salud hoy queda en ti. Mas no olvides que tu boca es otra fuente de infección. Cepillarte bien los dientes te protege. Cepilla y lavar es la respuesta. Cepilla siempre profundo cada diente y muela. Cepillar hasta llegar a todos los rincones de tu cavidad bucal. De tu cavidad bucal.
To hear what